Welcome to the Australian Dental Council Explainer podcast.
Glad to be here.
Right. So picture this. A patient is sitting in your chair. They came in for just a routine extraction, but suddenly they're sweating profusely.
Oh, that is never a good sign.
No, it's really not. And they're clutching their chest, complaining of this crushing band-like pain radiating down their left arm.
Classic presentation.
Yeah. So you administer a GTN spray, expecting the pain to subside, but it doesn't. In fact, it's getting worse.
Wow.
And in a matter of seconds, you aren't just a dentist anymore. You are a primary healthcare provider managing a literal life-or-death cardiac event.
And the decisions you make in those next 60 seconds, well, they'll be scrutinized. Not just by the medical community, but by the Australian Dental Council.
Which is terrifying. But before we unpack that intense scenario, we just want to lay down a quick but very important note. Everything we're discussing today is purely educational.
Right. This is not a commercial endorsement of any kind.
Exactly. We want to remind you, the listener, that we do not recommend or endorse any proprietary or, informal preparation courses.
Yeah, those courses are developed without ADC input.
Right. So we are simply here to objectively analyze the public, official source materials to help you learn.
Just sticking to the facts.
Exactly. So with that established, I want to warmly welcome you. Whether you are an overseas-trained dentist, an OTD, currently navigating the intense candidate journey.
Or maybe a dental student deep in your studies.
Yeah, or an Australian oral health therapist looking to stay sharp. We know exactly how high the stakes are.
Preparing for the ADC examinations is just a massive undertaking.
It really is. You're balancing clinical excellence with some incredibly dense administrative and medical guidelines. We see you, and we're here to help lighten that cognitive load.
Because there's a lot to cover.
There is. The mission of today's deep dive is laser-focused. We are looking squarely at the 2025 to 2026 ADC assessment landscape.
The new blueprint.
Exactly. Specifically, we are going to decode the chronic condition management guidelines and the intricacies of clinical pharmacology that you absolutely must know.
And we're pulling directly from the official ADC handbooks, the Chronic Conditions Manual, and
the big one, the newly updated Therapeutic Guidelines Oral and Dental version 4.
That's right.
Okay, let's unpack this. Because to truly grasp how to study chronic conditions, you first need to understand the fundamental shift in how the ADC tests this knowledge.
Yeah, if you look at the 2025 blueprint, they have completely moved away from asking candidates to just, recite a list of drug side effects.
Right. The new ADC exam is like a flight simulator instead of a written driving test.
That is a great analogy. The exam has been entirely restructured around clinical reasoning. The current blueprint relies heavily on scenario-based questions, or SBQs.
And there are a lot of them, right?
Oh, yeah. Over a 2-day written exam, you face 280 of these computer-based scenarios.
Wow.
Yeah, 240 are scored and 40 are unscored. But the examiners, they aren't interested in isolated trivia anymore.
They want to see how you think.
Exactly. They are evaluating specific competency clusters, primarily clinical information gathering and management planning.
I sometimes hear candidates complain that taking a medical history feels like an administrative hurdle, like before getting to the quote-unquote real dentistry.
Right, but the ADC is actively punishing that mindset.
They really are. They're treating the medical history as a primary diagnostic tool.
Because it is a diagnostic tool. I mean, in an Australian clinical setting, treating the oral cavity in isolation is considered unsafe practice.
Unsafe, full stop.
Exactly. The exam expects you to demonstrate a holistic understanding of the patient. You have to weave together their systemic health, their pharmacotherapy, and even their socioeconomic context.
So if a scenario patient checks a box for hypertension, the subsequent questions won't ask you to just define blood pressure.
No, definitely not. They will ask how that patient's specific antihypertensive medication alters your surgical approach.
Or how it interacts with a vasoconstrictor in your local anesthetic.
Exactly. It's all about application.
Which means we need to look closely at the underlying physiology. And here's where it gets really interesting. Let's look at one of the most heavily tested, complex systemic issues.
Chronic kidney disease.
Yes, CKD. At first glance, a candidate might wonder, why does a dental exam obsess over renal pathology metrics? We aren't nephrologists.
Yeah.
But if the kidneys aren't functioning, the entire pharmacokinetic profile of the drugs we use changes, right? I imagine the clearance rates just plummet.
That's the core issue right there. The oral cavity is intimately connected to the body's clearance systems. Let's ground this in the technical definitions straight from the Chronic Conditions Manual.
Okay, lay it on me.
So CKD is diagnosed when a patient has an estimated glomerular filtration rate, the eGFR, of less than 60 milliliters per minute per 1.73 meters squared.
Okay, less than 60.
Right. Alternatively, it can be diagnosed through evidence of physical kidney damage, like a persistent positive albumin-creatinine ratio, or ACR.
And we need to know those specific thresholds for the exam, don't we?
You absolutely do. The ACR thresholds are greater than 3.5 milligrams per millimole for females, or 2.5 for males. And that has to last for 3 or more months.
Okay, so just to make sure I've got this, the eGFR measures the flow rate of the filtered fluid through the kidney.
Correct.
And the ACR measures protein leaking into the urine because the glomerular filter is, well, essentially damaged.
Exactly. It's a structural damage marker.
But how does a dentist actually use those specific numbers in the chair? Like, if a patient presents with an eGFR of 45, how does that mathematically change my management plan?
Well, what's fascinating here is how these metrics dictate pharmacological management.
Mm-hmm.
You have to look at the half-life of the medication you're prescribing.
Right, because if it's not clearing, it's staying in the body.
Exactly. Let's take amoxicillin, for instance.
Mm-hmm.
A significant percentage of that drug is excreted unchanged by the kidneys.
Okay.
So if the eGFR has dropped from a healthy 90 down to 45, the kidney's filtration capacity is basically halved.
Meaning the drug stays in the systemic circulation much longer.
Right. So if you prescribe a standard dosage frequency,
Yeah.
the drug will just accumulate.
Mm.
And that can potentially lead to neurotoxicity or really severe gastrointestinal issues.
Oh, wow. So the ADC expects you to use that eGFR to actively adjust the dose or extend the dosing interval.
Exactly. You must adjust.
And it isn't just antibiotics, is it?
No, not at all. The exam frequently tests dosage modifications for analgesics and even diabetic medications, like adjusting the maximum dose of metformin based on creatinine clearance.
Right.
You will absolutely see scenarios requiring you to adjust medication protocols based on these renal metrics.
Which leads us to one of the most critical, highly tested interactions in the entire ADC blueprint.
The triple whammy.
The triple whammy. It sounds like a colloquial term, almost like a joke, but it represents a massive liability in clinical practice.
It's a very serious trap.
Let's break down the mechanics of it.
Yeah.
So the 3 drugs involved are a non-steroidal anti-inflammatory drug, an NSAID, like ibuprofen,
Right.
combined with an ACE inhibitor or an angiotensin II receptor blocker,
Yep.
an ARB, and finally, a diuretic.
And the scary part is, many dental patients present to the clinic already taking 2 of those drugs.
Right, the ACE inhibitor and the diuretic, usually prescribed by their physician for hypertension.
Exactly. They're already on them.
Then they come to us with a throbbing toothache, and our first instinct as dentists is to, reach for an NSAID to manage the inflammatory pain.
And the moment you prescribe that NSAID, you have completed the triad.
And potentially triggered acute kidney injury.
Yes. The ADC tests this relentlessly because the mechanism of this interaction is entirely predictable if you understand renal hemodynamics.
Right. Let me try to map out that mechanism because this is where the HIW and the WHY really matter for the exam.
Go for it. Let's hear it.
Okay, so the glomerulus in the kidney has an inlet pipe, right, the afferent arteriole,
Correct.
and an outlet pipe, the efferent arteriole.
Yeah.
So to filter blood, there has to be pressure inside that glomerulus.
That's a solid conceptual model. Keep going.
So an NSAID blocks prostaglandins, which normally keep that inlet pipe open.
Right.
By giving ibuprofen, I am essentially constricting the afferent arteriole, which reduces blood flow into the filter.
Exactly. You're choking off the supply.
Meanwhile, the patient's ACE inhibitor blocks angiotensin II, which normally keeps the outlet pipe constricted.
Yep.
So the ACE inhibitor dilates the efferent arteriole, letting whatever blood is in there just drain out rapidly.
And then
Add in the diuretic, which has already depleted the patient's overall blood volume.
and the pressure inside the glomerulus just drops to 0.
Wow. A complete hydrodynamic collapse.
Exactly. The filtration completely stops and the patient goes into acute renal failure. You've just explained the exact mechanism the ADC wants you to recognize.
It's terrifying when you break it down like that.
It is. On the exam, when you are in the clinical information gathering phase, you must spot that the patient is on an ACE inhibitor and a diuretic.
You have to flag it immediately.
Right. Then, in the management planning phase, you must actively pivot away from NSAIDs. You choose an alternative analgesic pathway, like paracetamol.
Because paracetamol doesn't disrupt renal prostaglandins to the same degree.
Exactly. It's safe for that patient.
It's all about recognizing that domino effect. And, the physiology gives us a pretty natural transition here.
How so?
Well, If a patient's kidneys are failing, their vascular system is almost certainly compromised, right? Endothelial dysfunction and CKD naturally accelerates atherosclerosis.
Oh, absolutely.
That means by the time a patient's eGFR drops significantly, they almost certainly present with severe cardiovascular comorbidities, like hypertension or dyslipidemia.
We are deeply intertwined.
Right. So we can't talk about renal clearance without talking about cardiovascular risks and anticoagulants.
Managing cardiovascular emergencies and navigating bleeding risks are core competencies for the ADC.
So let's tackle the bleeding risks first, because the landscape of oral anticoagulants has shifted so dramatically, and I know candidates often struggle with how to manage this on the exam.
It is a major area of confusion.
I really want to focus on the difference between managing a patient on warfarin versus the newer direct oral anticoagulants, the NOACs, like dabigatran or apixaban.
Right, the newer generation.
Yeah. I like to think of managing warfarin as driving a manual transmission car. You have total visibility and control.
I like that.
You can check the RPMs via their INR, the International Normalized Ratio, which obviously measures how long it takes the blood to clot.
Right.
If the INR is too high, you can easily hit the brakes with a specific reversal agent, like vitamin K. But the NOACs, they feel more like automatic cars.
They do, yeah.
They are incredibly convenient for the patient, but they leave the dentist with way fewer manual controls and no simple INR blood test to check right before an extraction.
That's the real challenge.
So how does the exam expect candidates to navigate NOACs safely?
Well, your manual versus automatic analogy perfectly captures the clinical tension there. According to the Australian prescriber guidelines, warfarin is a known entity.
Right, we're comfortable with it.
We have over 50 years of robust, evidence-based dental protocols for it. With warfarin, the exam will test your adherence to strict INR parameters.
Okay, but what about the NOACs?
NOACs lack that universally standardized point-of-care testing, so the exam expects you to manage NOAC ambiguity by focusing heavily on the timing of the procedure.
Ah, timing around the drug's half-life, right?
Yes, exactly. For a standard low-risk extraction on a patient taking a NOAC, you generally do not instruct the patient to alter their dose.
Really? You don't tell them to skip it?
No, you don't. Instead, you time the surgery to occur as late as possible after their most recent dose.
When the plasma concentration of the drug is at its lowest trough.
Spot on. Then, you rely intensely on local hemostatic measures, sutures, oxidized cellulose sponges, and pressure.
Okay, that makes sense. But because warfarin has such quantifiable parameters, the ADC loves to use it for really specific scenario questions, don't they?
They absolutely do.
There is a well-documented ADC practice scenario regarding a patient named Alexander.
Oh, I know the one.
Right, so he's 64 years old, taking warfarin for atrial fibrillation. His INR is tested within 24 hours of the appointment and sits at 2.4. And he presents needing an extraction.
Right.
So what is the management plan?
Many candidates overthink this one.
No.
They see warfarin and immediately assume they need to consult the patient's cardiologist to lower the dose.
Or they just decide to delay the procedure entirely out of fear of uncontrolled hemorrhage.
Exactly. But stopping the warfarin puts the patient at risk of a thromboembolic event, like a stroke.
Which is vastly more dangerous than a bleeding socket.
Much more dangerous, which is why delaying or altering the dose in this scenario is the incorrect answer.
Okay, so what's the evidence-based exam response?
Proceed with the extraction. An INR of 2.4 falls well within the safe therapeutic range for minor oral surgery.
Which is what, up to 3.0?
Typically an INR of up to 3.0, yes, and sometimes even up to 4.0, depending on the exact procedure and your local guidelines.
Okay, so you just do the extraction.
You perform the extraction, you ensure excellent local hemostasis, and you provide really clear post-operative instructions.
Right.
And interestingly, that specific scenario also tests your treatment sequencing.
How so?
It notes you should not initiate immediate prosthodontic replacement. You manage the acute surgical issues safely without overcomplicating their systemic care.
Okay, so proceed, but proceed with local control. That's a great takeaway.
Definitely.
Now, let's circle back to that terrifying scenario I introduced at the very beginning of this deep dive. The patient clutching their chest.
Right, the cardiac event.
Yeah. Another area where candidates get tripped up is differentiating and managing medical emergencies in the share, specifically distinguishing between angina and a myocardial infarction, an MI.
This is a critical distinction for the exam. Both conditions involve myocardial ischemia, right? A lack of oxygen to the heart muscle.
Yeah.
And both can present with that classic band of crushing chest pain radiating to the jaw and the left arm.
Mm.
But the pathology and therefore your emergency response is fundamentally different.
Right, because angina is usually a transient ischemia. The coronary artery is narrowed, and the oxygen demand just temporarily exceeded the supply.
Often triggered by the stress of being in the dental chair.
Exactly. The patient usually knows their history and brings their medication.
And that medication is the primary diagnostic differentiator. The pain of angina is typically relieved by resting and administering a vasodilator.
Specifically, GTN, glycerol trinitrate spray, under the tongue.
Exactly. The GTN dilates the blood vessels, it reduces the heart's workload, and it resolves the ischemia.
But if I administer that GTN spray, wait a few minutes, and the crushing pain is not relieved,
Or if the patient's condition actively worsens.
then you must operate under the assumption that the ischemia is not transient. You're dealing with a myocardial infarction.
A heart attack. The coronary artery is likely completely occluded, and heart muscle tissue is actively dying.
At that moment, the protocol shifts instantly. I mean, I'm no longer managing dental anxiety or transient chest pain.
The protocol becomes immediate and life-saving. You stop all dental treatment.
Right.
You initiate the PABC protocol. Posture, airway, breathing, circulation.
Okay, so position the patient comfortably, usually sitting up to ease breathing.
And you call 000 for an ambulance immediately. You administer high-flow oxygen if it's available, and you prepare for basic life support.
The exam is testing your situational awareness there, really.
Yes, to recognize the exact moment a situation escalates beyond dental management and requires emergency medical intervention.
Wow. Okay, so we've covered the hemodynamic collapse of the triple whammy, adjusting dosages based on EGFR math, the timing of NOACs versus warfarin INR parameters, and differentiating an MI from angina.
It is a lot to take in.
The sheer volume of physiological interactions a candidate is expected to know is staggering. So what does this all mean? You, the listener, need a definitive clinical framework to make these decisions under exam pressure.
You definitely do.
And that leads us directly to the primary resource tested by the ADC, the therapeutic guidelines.
Right. For clinical pharmacology in Australian healthcare, the therapeutic guidelines are the absolute standard.
And in September 2025, the Therapeutic Guidelines Oral and Dental version 4 was released.
So if you are sitting for the 2026 written or practical exams, version 4 is the exact framework you will be tested against.
And 2026 is a major milestone for this publication, isn't it?
It is. It marks the final year they are producing the print edition of the guidelines.
What generations of dental students affectionately call the clown book because of its famously distinctive, colorful cover.
Yeah, the clown book is going away. Moving forward, it is transitioning to a completely digital, constantly updated platform.
Which makes sense. The shift to a digital ecosystem reflects just how rapidly medical consensus evolves.
Exactly. And for the 2026 exams, there are several highly specific updates in version 4 that candidates must thoroughly understand.
Okay, let's examine the shift in pregnancy classifications first.
Sure.
Because in the past, we relied heavily on the old TGA, the Therapeutic Goods Administration categories, like Category A, B, C, D, and X.
We all memorized those letters.
We did, but my understanding is that the new guidelines are moving away from those simple alphabetical categories.
Right, because they were often misinterpreted as a strict hierarchy of safety rather than descriptions of the available evidence.
Ah, I see.
That's the exact rationale. The guidelines now emphasize descriptive texts over arbitrary letters to guide safe prescribing.
Okay, so for the exam, what are the major pharmacological updates regarding pregnant cohorts that we must memorize?
There are two main ones. First, the guidelines specifically validate the safety and preference for using articaine for local anesthetic nerve blocks.
Really? Why articaine specifically over older legacy options like lidocaine?
It comes down to protein binding. Articaine has a very high protein binding rate in the maternal blood,
Okay.
which significantly limits the amount of the drug that can cross the placental barrier.
Oh, that's brilliant. Okay, so articaine is preferred. What's the second update?
The second major update is the inclusion of tapentadol. It's now listed as a viable option for managing severe acute pain in specific pregnant cohorts.
Oh, wow.
Yes, specifically when other standard analgesics, like NSAIDs, are contraindicated due to gestational risks.
Okay, so candidates need to update their internal flashcards immediately on those two drugs, articaine and tapentadol.
Absolutely.
Now, what about penicillin? We have to talk about antibiotics.
Yes. Version 4 introduces a rigorous standard for evaluating penicillin hypersensitivity.
Because historically, if a patient reported an allergy to penicillin, practitioners would often just reflexively prescribe a broad-spectrum alternative, right? Like clindamycin.
Right, but the new guidelines strictly prohibit that reflexive behavior.
Really?
Yes. You must clinically differentiate between a non-severe and a severe penicillin hypersensitivity.
Okay, but how does the ADC expect us to differentiate that in a written scenario?
You look for the mechanism of the reaction in the prompt. A severe hypersensitivity is a type I reaction. It's Ig-mediated.
Okay, IgE mediated.
This presents as immediate anaphylaxis, angioedema, or bronchospasm.
The really scary stuff.
Right. A non-severe reaction is typically a delayed T-cell mediated response, presenting as a mild maculopapular rash days after taking the drug.
Oh, okay, so why does identifying that specific immune pathway matter so much for our management plan?
Because it completely changes your prophylactic options, particularly for high-stakes procedures, like preventing infective endocarditis in patients with prosthetic heart valves.
Oh, I see.
If the patient has a history of a severe Ig-mediated anaphylaxis to penicillin, you must entirely avoid all beta-lactam antibiotics.
Including cephalosporins.
Yes, including cephalosporins due to cross-reactivity.
Right, okay.
But if the history only indicates a non-severe delayed rash, the guidelines now actually support the use of certain cephalosporins like cephalexin for prophylaxis.
Wow. So the exam wants to see that you understand this immunological nuance and you don't just reflexively prescribe clindamycin.
Exactly, because clindamycin carries a very high risk of Clostridioides difficile infections.
That is such a crucial distinction, and I think that perfectly sets up the third major update in version 4, antimicrobial stewardship.
Yes, this is a huge focus area now.
This is no longer just a biological concept about, which drug kills which bacteria. It is an ethical framework embedded directly into the ADC's professionalism and health promotion domain.
Antimicrobial stewardship is the ethical responsibility of every clinician to actively limit unnecessary antibiotic use. We have to combat the global crisis of antimicrobial resistance.
Right. So let's put this into a concrete exam scenario.
Okay.
Mrs. Smith comes into your clinic. She has a localized periapical abscess on a lower molar.
Okay.
There is no facial swelling, no systemic fever, no lymphadenopathy. But she forcefully demands a script for amoxicillin because, quote, that's what my old dentist always did to fix it.
We've all had that patient. That scenario tests your clinical restraint and your communication skills.
So giving her the script is wrong.
The correct answer is absolutely not to write the prescription just to appease the patient. The correct exam response is to manage the source of the infection locally.
Through extirpation of the nerve or extraction of the tooth.
Exactly. And to politely, ethically, and firmly refuse the systemic antibiotic. You must educate the patient on why antibiotics are not indicated for localized infections and document that discussion.
It all comes back to that holistic, integrated view of patient care. Wrapping this deep dive up, we can see how all these disparate threads connect.
You really do.
Technical knowledge, like calculating an EGFR to adjust drug clearance, knowing the INR threshold of 2.4, mapping the hemodynamic collapse of a triple whammy, understanding Ig-mediated penicillin allergies.
None of this is just exam trivia.
No, it merges directly with the ADC's overarching goal. They are trying to produce safe, highly competent primary healthcare providers who can operate seamlessly within the broader Australian medical system.
And if we connect all of this to the bigger picture, this raises an important question for the future of our profession. We are standing at a technological crossroads.
So you really are.
As the Clown Book officially goes digital in 2026, and as dental clinic software increasingly integrates automated medical history alerts.
Like software that will instantly flag a triple whammy interaction before you even pick up an instrument.
Exactly. How will the definition of a competent dentist change? Will the future of dental practice rely less on our ability to memorize complex drug interactions and much more on our ethical judgment?
Like our communication skills with patients like Mrs. Smith.
Right. And our real-time digital literacy in the clinic.
It's a fascinating thought to leave on. The machine might flag the warning on the screen, but the clinician still has to understand the physiology to make the final human decision. For more dental examination prep tips and clinical deep dives, please subscribe and share this episode.